Hi, everyone. My name is Kennedy Slayton, and for my contemporary issue, I chose to focus on the topic of suicide. And so, with suicide, as we know, it is one of those well known public issues that everyone has encountered in some way, shape, or fashion, whether it's been personally or whether you've witnessed it or known of it through a family or a friend, or whether it's through news and just hearing the sad reality of people committing suicide. And so, this is an issue that accounts for the death of nearly over 800,000 individuals worldwide per year. And rates continue to rise, especially in the US over the past couple of years, according to Tareki in 2019. And so the article of Tareki goes on to define suicide as having thoughts about ending one's own life, whether it is actively and they have a plan kind of set in motion or it's passively. And so some terms that stem from this issue is suicidal behavior, suicide attempts, suicidal ideation, self-harm, and interpersonal difficulty. And so as we are looking through research, it has come to show that this issue of suicide is multifaceted and it is multidimensional. And in identifying behaviors of a suicidal person, it isn't a one shoot fits all type situation. And it looks different for everyone. And it even affects our children. And in the article by Lady et al., it states that it has become a major cause of youth mortality throughout the world, with gender being an important factor where male adolescents seem to have more incidences than female adolescents. And that was noted by Morgan et al. And so as you see here, just listing kind of what is suicidal behavior and it being a global cause of death and suicide becoming the 15th leading cause of death today, and just self-harm and what that is, and it being more so a coping mechanism for individuals who don't know how to deal with difficult situations and can serve several functions. And so moving on, we want to talk about the ethical principles that comes with treating a patient with suicidal ideations. And so suicide occurs in people of all ages and backgrounds. And so in working with individuals with this presenting issue, Montreal et al.'s article highlights three ethical issues that we as clinicians may come to face. The first being ethical issues arising from discrete decisions and acute care settings. The second being ethical issues arising from the therapeutic relationships in chronic care. And the third being organizational factors and their effect on care. And so the ACA, fundamental principle of non maleficence, becomes another presenting ethical issue because it can contradict a suicidal patient's autonomy regarding ending one's own life, um, end of life decision making, leading to ethical dilemmas for healthcare providers. Another rising issue for maintaining ethical issue maintaining ethical principles is confidentiality. It gets a little hard when we are working with a patient where trust needs to be instilled, that therapeutic relationship is very important, but also being a mandated reporter. And if mention of harm to self is noted, we have to break confidentiality, unfortunately. So that becomes the tricky end of working with this issue in a clinical setting. And so the treatment process poses more ethical issues and principles that we must be aware of and approach precautiously. And so, some other issues that may arise is just the lack of cohesion on healthcare provider teams, emotional toll, lack of resources, professional support being low, and also healthcare providers just not being trained enough. And so, in saying all of these things, they fall back on the codes of ethics for the ACA and the AACC, the American Association for Counseling Christian Counselors. And so, particularly, what stood out is Section C of the ACA Code of Ethics and the professional responsibility, our role and what we must do for our clients. And the confidentiality portion stood out the most from that section. Um, Within the Code of Ethics for the AACC, affirming human health, affirming human worth, and protecting people from deadly harm was one mention that definitely stood out that I see playing a huge role in this issue. We want to make sure that these clients know that they do have a worth, and we also want to protect them from harm. We also want to still apply the other aspects of the AACC Code of Ethics, which is just compassion, competence, consent, confidentiality, having cultural regard, and just case management. And so moving on to spiritual implications, this is an aspect that not all individuals may have, but bringing the ideology of it into a session might be beneficial. But the views of suicide within the spiritual realm gets tricky. And so when we involve the implication of spirituality, it becomes a deeper issue that conflicts with the sixth commandment, thou shalt not kill. And that is referring to self as well. And so there are many attitudes towards suicide and has generally been negative among all of the world's major faith traditions, according to Cox 2018 article. And as I did furthermore research, I found that Kosa Nicotini's and Siegelman's 2015 article did a really great job at exploring why this exploring the why for spiritual reasonings behind the opposition towards suicide. I think most people are opposed to the idea of suicide, but within the spiritual realm, there is definitely a strong sense of this should not happen. It goes against our beliefs entirely. And so just to read a few short passages that I found within the article that states where their thought process, where the idea of spirituality opposing suicide, where their belief stands in that. And so reading off, many Christians believe that when someone takes his or her own life, they go to hell. This originates from the very early days of Christianity, when religious doctrines made it clear that suicide was a human morality and that is against God's will. It also makes notes of how the Bible doesn't teach on suicide, but there are several examples of it within the text, such as Judas, King Saul, and Samson. However, suicide was not officially labeled an unforgivable sin until St. Augustine determined that it violated the commandments. And so, furthermore, in the Cox 2018 article, I have found that in Hebrew scripture, implicity condemned suicide, and both Jewish and Christian commenters have forbidden it. But the problem lies in that time to understand the root and the individualized reasoning of why one might consider taking their own life and actually doing it and following through with it. They view it as being bewitched or possessed. And so the overall relationship between an individual's religion and their social are oftentimes ignored in the clinical setting. And that was according to Cosa Nicotini and Siegelman's article 2015 as well, mentioning that. And before moving on to the next slide, I did want to provide just a Bible verse that I have found that can be applied to why someone may be feeling a certain way and where it might stem from, if that makes any sense. So, the thief comes to steal one's joy. The thief comes only to steal and kill and destroy. I have come that may have life and have it to the full. So oftentimes with people who have suicide, their mind is what's under attack. And so reading this verse is where I was like, this can be applied because now their mind, the thief is stealing their mind, is stealing and killing and destroying. So moving on, we want to talk about treatment with all the information that has been provided as to what suicide is and how it is viewed. What does treatment look like? And so, for clinical integration, it has varying approaches, but the most important is forming that therapeutic relationship. It has been seen to help shift the state of some clientele's minds into a non crisis situation because the initial difficulty of developing interpersonal connections has been found. And so it is important that our models practice with suicidal clients include how clinicians have developed trust and caring relationships, as Cox et al. 2024 article states. And so moving throughout treatment as well, it is important that we keep in mind treatment latency. How much time is in between each session to help these clients? And it has been found that if it is more consistent, if the time frame is more close in proximity, more change, more positive results can come about. And so that is just a huge element in the treatment. And that was mentioned in Probert Lindstrom's et al.'s 2024 article. So some approaches and techniques for clinical integration is single session suicidal crisis. That was in the Cox et al. Article. Dialectical behavior therapy, DBT, cognitive therapy, collaborative assessment and management of suicidality, stabilization, oriented interventions, teachable moment, brief interventions, motivational interviewing, and attempted suicide short intervention program. These are all of the many approaches one can take, and all of them have been found to have a positive impact on clients who have suicidal ideation. When it comes to spiritually integrating some ideas into the session of helping the client, um, the implementation for certain individuals can help clients learn how to use their religious and spiritual beliefs to address their mental health concerns. And that was stated in the Bartley and Cashwell 2014 article. And so, furthermore, research has shown that there is evidence to suggest that religion may help people better cope with life stresses, reduce incidences of depression, and enhance social support, and to provide sources of hope and meaning. Cook 2018 had provided that knowledge for us. And so there are certain steps one may take with spiritually integrating. You want to first see if that is something that the client wants. And if that is so, Johnson 2013 has provided 5-step process as in how to integrate it. And so first, being open to the client's defined spirituality. Second, utilizing spirituality for resourcing. Third, inviting spirituality to inform personal integrity, also evaluating life structures and remembering and committing to spiritual practice. With this clientele, with people who have suicidal ideation, having a routine, having structure, having a framework is very important. So if we are going to integrate spirituality, we must be consistent with that practice across the board, but also pay attention to if the client is taking to what is being said and in the way the integration is being applied. And so some other techniques that can be used is just sacred text, seeking forgiveness for others, practicing mindfulness and meditation, and drawing upon sensory techniques such as yoga. And so ultimately, clinicians instilling hope and providing that framework can really help steer people with the thoughts of suicide shift from a space of crisis to a space of mental stability. And through varying approaches to help these clients see the reality of their decisions and how even in dark spaces there is light, change can come about because they are now in a safe space. And understanding them on an individualized level can help them see that. And so I had found a Bible verse that I found kind of applicable to the spiritual integration of just asking for help and it will be given to you. If you seek, you will find. Knocking, the door will be open to you. For everyone who asks receives, and the one who seeks finds, and the one who knocks, that door will be open to you. And I think when we work with people who have thoughts of suicide, they oftentimes have a different way of showing they want help. I ultimately believe no one necessarily wants to take their own life. They just got into a place where they feel like all hope is gone and that's their best option. And so if we pay close attention to people who has strongly and bravely admitted that they are not okay and that they need help, we need to make the right actions and take the right steps to ensuring that we show up for them, that we do what's best for them, and we understand who they are on an individualized level. And so, with such a heavy topic, here are some resources for those who know or are personally affected by suicidal behavior or suicidal ideation and need help but don't know which direction to turn. So there are multiple crisis hotlines that are available to everyone 24/7. I also provided links on how one can talk to someone who has expressed wanting to commit suicide or some level of self-harm and what what are those signs and how to pick up on those things I have also placed in the link as well. And so just to end off, I think this topic of suicide is such a very harsh reality because when someone makes such an act, it is kind of like instinctual to be like, why would they do such a thing? You don't really understand like the root of it. And I think that is what's important on all levels, on a clinical level and on a spiritual level. We must understand that kind of the root of people taking such a step is because there is some level of fear within them or a high level of fear. There could be some level of disgust or a low level of disgust or sadness and anger and then just the lack of joy being there. And so I hope this presentation was very helpful to you guys and you were able to take much from it. So that is all for this presentation, and I do really hope you enjoy.